Welcome to The Debate. Today we're diving into, well, one of the most pressing national crises we face, the convergence of opioid addiction and really pervasive mental health needs. The question isn't if we need to act, but how we should prioritize our policy focus. Should the main thrust be, supply reduction, tightening accountability, enforcing order? Or must we prioritize scaling treatment on demand, implementing robust harm reduction, and achieving comprehensive health parity? I'll be arguing for the health-first approach, really emphasizing access and immediate mortality reduction above all else.
And I come at this from more of a structural perspective. While treatment is clearly essential, absolutely, I'll be presenting the case that deterrence and community order are in fact necessary preconditions for successful recovery and public safety. So this means our priority has got to focus on cutting off the supply chain, enforcing stricter accountability across the board, and ensuring that treatment interventions deliver measurable, structured results.
Right. Our perspective is rooted in treating addiction fundamentally as a chronic health condition, much like diabetes or heart disease. And when you view it through that lens, the primary policy imperative, it must be scaling access to evidence-based medical interventions. Why? To drastically cut mortality and disease. Specifically, we have to focus intensely on medications for opioid use disorder, or MAUD, drugs like buprenorphine, methadone, naloxone. We need to see these integrated ubiquitously in primary care settings, in emergency rooms, and critically inside correctional facilities. And that includes same-day induction. The evidence is it's clear. MAUD in jail models, they've been shown to drastically cut post-release overdoses, which, as we know, are often fatal because tolerance changes during incarceration.
Beyond direct care, we absolutely must mandate genuine enforcement of mental health parity laws, make sure insurance covers this chronic disease properly, and we need to scale up our crisis response, things like the 988 hotlines and mobile crisis units, to deflect individuals away from police interaction and, frankly, overwhelmed emergency rooms. This is the fastest, proven path to saving lives.
Okay, that's a compelling point regarding the health imperative. I grant you that. Though, I would frame the foundational problem a bit differently. Look, we cannot treat the demand side successfully if the supply side remains a flood. Deterrence and order are the baseline requirements for both public safety and recovery. We simply must aggressively stop the flow of potent synthetic opioids like fentanyl and now xylazine at the source. This demands sophisticated, high-tech action against the supply chain. Think ports of entry technology, imposing tougher trafficking penalties, and swift prosecution of large-scale dealers. This includes using tools like cartel sanctions and, where necessary, extraterritorial actions. Domestically, the focus has got to shift to accountability. We support what we call Drug Courts 2.0. These are programs that mandate evidence-based treatment for nonviolent users, in lieu of incarceration. But crucially, these courts must require strict compliance, consistent drug testing, mandatory attendance. Real-world examples confirm these programs reduce recidivism only when compliance and expectations are rigidly enforced. Furthermore, regulatory discipline, like using prescription drug monitoring programs or PMDPs, has proven effective in lowering high-risk opioid prescribing rates. We cannot simply offer enablement without firm, enforceable expectations that lead to recovery and, just as importantly, community order.
I understand the desire for that measurable structure, but let me offer a different perspective on that idea of enablement versus, life-saving measures. Critics of a law enforcement-heavy approach, they often fear that a punitive focus inherently deters help-seeking behavior, right? They worry that rigid guardrails will actively undercut immediate harm reduction measures that save lives now. Think about naloxone, the overdose reversal medication. It's simple, it's effective, and evidence shows wide distribution slashes mortality. So how can policy justify delaying or restricting life-saving naloxone distribution with bureaucratic hoops or location-based compliance requirements? The health-first approach argues that the non-negotiable goal is reducing the death rate, period. Any impediment to that goal, especially one based on sort of philosophical fears about addiction as a moral failure rather than a medical necessity, is just counterproductive and incredibly costly in human terms.
Well, I'm not entirely convinced by the argument that community order is somehow secondary to immediate harm reduction. While I absolutely acknowledge the life-saving necessity of naloxone and syringe services, I mean, they keep people alive for a chance at treatment. That's undeniable. These services must be implemented with strict nuisance controls and, frankly, competent localized management. We can't ignore the reality of community acceptance. The concern about neighborhood impact, public drug use, discarded syringes, loitering, it's a real, non-negotiable metric. If these programs are poorly managed, they lose local trust, which ultimately stalls the broader effort to scale necessary services. So harm reduction must be explicitly paired with rigorous pathways to treatment. This means incorporating safeguards, requiring program staff to manage litter and loitering, ensuring adequate security.
We prioritize order not for punitive reasons, but because deterrence and order are fundamental prerequisites for sustained public safety and for creating a stable environment where people can actually sustain recovery. Without community buy-in, even the best-intentioned programs fail.
I see the political necessity of community buy-in, I do, but I worry we're conflating public comfort with public health outcomes. You mentioned nuisance controls, and yes, discarded syringes are a public hazard, no question, but they don't carry the immediate mortality risk of, say, a delayed MOUD induction. We need to drill down into the highest leverage point for impact. If we save a life today through naloxone, that individual lives to potentially enter treatment tomorrow. If we prioritize nuisance control and force them into punitive settings first, we often delay care and actually increase their risk of death. What is the evidence that demanding immediate structured pathways alongside harm reduction doesn't simply scare off the hardest to reach individuals, the people who need the service most? The only metric that matters right now, today, is mortality, and deflection via health services is the proven way to move that number down.
The metric that matters is sustainable recovery and safety for everyone. Let's pivot back to supply for a moment, which is a structural precondition for either outcome you're talking about. We have to maintain aggressive trafficking pressure. We need sophisticated tools like financial sanctions, ports of entry technology to deter these predatory dealers. The sheer volume and lethality of the fentanyl and xylazine crisis mean that focusing on external cartels and rogue prescribers isn't just important, it addresses the key drivers of today's crisis. If we don't aggressively target supply, which, let's be honest, is often overlooked in purely health-centric models, we are simply fighting a losing, very expensive battle against a constant tidal wave of illicit substances flooding our communities. We are not arguing against treatment. We are arguing that enforcement is the necessary guardrail to contain the crisis long enough for treatment to actually have a chance to succeed.
That's a compelling point regarding the sheer flow of novel synthetics. I'll grant you that. But have you considered that an overwhelming focus on border tools and the sort of drug war framework, it fundamentally misses the crucial element of sustained domestic demand? Arrests and seizures are useful metrics, sure, but they don't solve the core illness, the trauma, the pain, the despair that creates the demand in the first place. The market is incredibly adaptive. You shut down one supply route, another one springs up, often introducing an even more dangerous analog. We should be investing strategically in upstream factors, scaling alternative pain management techniques, vastly expanding trauma-informed care systems, and critically, saturating the market with MUD. Scaling treatment is the most effective way to permanently shrink the market demand for illicit drugs. Investing solely in enforcement without massively scaling health access, it just means the market demand will persist, making all the border actions temporary fixes at best. Criminalization failed to curb demand. Only proven health-first approaches will sustainably reduce disease and deaths.
I'm sorry, but I just don't buy the idea that the justice system should merely be a passive recipient of these health issues. It is a critical partner in structuring recovery. We strongly defend the use of structured treatment models like Drug Courts 2.0 that explicitly measure outcomes, not just presence but retention and compliance. We argue that public funds must be tied to performance contracts that reward providers based on metrics like retention rates and, yes, mortality reductions. This ensures that insufficient expectations don't sap program credibility. We need mandatory compliance, including regular drug testing and attendance, precisely to avoid the catch-and-release mentality that critics fear undermines the seriousness of the issue and the efficacy of the treatment itself. Accountability drives results.
I see why you prioritize that measurable structure. I do. But the critical vulnerability in that overly punitive structure is that it can backfire severely. Strict, mandatory compliance, punitive testing, it often deters individuals from entering treatment voluntarily. And it simply cycles them back through jails and prisons where, let's face it, evidence-based care is often absent or inadequate. Rather than focusing on accountability solely on the vulnerable individual, I propose that the highest leverage point for accountability lies in jail and prison health reform. We need universal MOUD during custody. That means every facility must offer methadone and buprenorphine, and a mandatory warm handoff upon release.
Okay, describe what you mean by a warm handoff. In practice, what does that look like?
A warm handoff means ensuring the individual leaves the facility with the medication in their hand, enough supply to last until their first confirmed booked appointment with a community provider within, say, 72 hours. This is an administrative necessity, really, and we hold the institution accountable if they fail to implement this, because the data shows post-release overdose deaths drop dramatically when this protocol is followed consistently. Accountability should fall on the systems that fail to treat addiction as the chronic disease it is, not simply on the patient if they relapse. If we mandate the structural change within corrections, we save more lives than any compliance testing regime ever could, I'd argue.
I agree that the warm handoff is a high-leverage intervention. Absolutely. But that only addresses a fraction of the population, those already arrested, already in the system. We still need compliance protocols for those not incarcerated, ensuring community accountability is maintained across the board.
Well, that brings us to acute crisis response in the community, doesn't it? I really want to emphasize the profound success we're seeing with scaling 988 hotlines and mobile crisis teams. These health-led teams are specifically designed to reduce arrests and unnecessary emergency room boarding. They act as a means to free up police and ERs from dealing with issues they are, frankly, poorly equipped to handle. We must commit to staffing these services 24/7 with clinical professionals ready to stabilize and connect individuals to mood and long-term care immediately. This health-first deflection model isn't just compassionate, it improves outcomes and overall community safety without relying on punitive measures first.
I appreciate the goal of deflection and the success of the crisis continuum in certain contexts. But we have to be realistic about high-risk situations. We insist on clear handoff protocols, especially when scaling up mobile teams. In many scenarios involving severe paranoia, potential violence, or high-risk intoxication, we need police co-responders. It's for the safety of the clinicians and the public. We cannot just divorce these services from the need to maintain the element of order and public safety in the moment. Diversion has to be managed effectively, perhaps using things like 23-hour crisis stabilization units and short-stay facilities. But the protocols must reflect that public safety is non-negotiable. If mobile teams are seen as ineffective or unsafe in volatile neighborhoods, they will quickly lose public support, and then we're back to square one.
Okay, I see the need for safety protocols, absolutely. But co-responding must remain focused on clinician safety, not on using the moment of crisis as an opportunity for arrest or, coercion and destructured compliance. Our core argument remains that the evidence overwhelmingly supports a health-first approach, prioritizing ubiquitous treatment access, mandatory MOUD implementation, comprehensive deflection models. That's the fastest, most effective way to measurably save lives and reduce the total disease burden. This focus on mortality reduction, which really is the core strength of a health model, addresses the crisis internally, shrinking the demand for illicit drugs over time.
And my position, to sum up, is that accountability and enforcement are crucial partners in this. We need strong regulatory discipline both at the border to interrupt the supply of these dangerous novel synthetics and in structured community programs to ensure effectiveness. We must guarantee that communities are safe and that treatment providers deliver measurable, sustained results via strict contracts and compliance. Ultimately, listeners must weigh which policy measure is their priority. Is it primarily reducing the immediate death rate, or is it restoring public safety and community order through enforced accountability? Both must function together, yes, but the policy priorities and, crucially, the metrics of success remain fundamentally distinct.